To begin, this Health Inequities in Cities dashboard is hosted at the Urban Health Collaborative and has been developed in partnership with the Big Cities Health Coalition and with support from the Robert Wood Johnson Foundation and the de Beaumont Foundation. We have a great team that has been collaborating to develop various elements of the platform. You can see their names listed here. So it's a really collaborative effort, and you can see links to the dashboard on your screen. As you all know, cities are home to large health inequities, including inequities in COVID-19 related outcomes. And describing and quantifying the magnitude of these inequities and examining how inequities vary over time and across cities can be important for understanding the drivers of health inequities, for targeting resources, and also, most importantly, for developing policies and interventions to eliminate inequities. And so this dashboard is really nested within a broader project that includes as its first objective to develop and maintain a public access dashboard and web interface that allows descriptions, visualizations, and comparisons of COVID-19 outcomes, and in particular, COVID-19 inequity indicators in cities of the Big Cities Health Coalition over time. Other parts of the project, which we will not focus on today, are to conduct data analysis in order to identify city, neighborhood, and other factors associated with COVID-19 related outcomes and health inequities, and to characterize public health policies aimed at minimizing the impact of the COVID-19 pandemic, and in particular, focused on reducing inequities in the COVID-19 pandemic. So we have developed an equity framework that is detailed in the dashboard itself, but I just want to highlight a few things about it. First is that, of course, we see inequities as driven by structural and systemic factors. And what do I mean by these words? Structural has to do with the way the structure of society, for example, class structure. And systemic, we use the word systemic because we know that these inequities arise from the functioning of systems that bring together many different factors that generate these inequities and have generated them over time. Factors that involve drivers and also manifestations at multiple levels, at the levels of individuals themselves, at the levels of neighborhoods, at the levels of cities, and also that there are many interactions across levels. So for the purposes of describing inequities in the dashboard, we have identified factors at 3 different levels, as shown in the figure. At the level of individuals, there are many characteristics of individuals that generate differences across social groups in COVID-19, occupation, income, education, and race ethnicity, of course. Race ethnicity is what we are the only individual level indicator that we have in the dashboard at this time, because it is the only one available. And even race and ethnicity is not available all the time and for all indicators and for all cities. We also focus on neighborhood level measures. So characteristics of neighborhoods such as the CDC Social Vulnerability Index and its components or indicators of poverty, or other measures at the neighborhood level that have to do with occupational structure, for example, or other characteristics that may be associated with COVID-19 outcomes and with differences in COVID-19 outcomes across neighborhoods. And last but not least, we also focus on indicators at the city level because there are also inequities across cities. For example, cities that differ in levels of racial segregation, cities that differ in levels of overall poverty, and cities that differ in levels of income inequality, as captured, for example, by the Gini index. And so you'll see when Usama walks us through the dashboard that you'll be able to visualize inequities using individual level, neighborhood level, or city level indicators. Very briefly, and Usama may elaborate more on this if there are questions, there's a complex sort of back end to this data dashboard that includes pulling in data from various sources. Currently, we are prioritizing using publicly available data from various online sources. The remaining data that is not available publicly has been requested directly from the cities. And we often use county proxies for cities that do not have city level data publicly available. And the data availability, as well as the format and way in which it is available, changes frequently. So we have to be constantly adapting the tools that we use to update the data. So this algorithm shows a little bit about some of the steps in that process. The development of the dashboard began in May of 2020. Funding started in June, and we have been through an iterative process involving the Urban Health Collaborative and in consultation with the De Beaumont Foundation, the Big Cities Health Coalition, and Robert Wood Johnson Foundation to develop this, the dashboard that we have today, and we have launched it publicly in January. So before turning it over to Usama, I just want to highlight a few challenges and caveats to keep in mind. One is that there is large heterogeneity in data availability. Another is that completeness and timeliness of the data also varies across cities. And so does the data access and the ease of access. So these are some of the challenges that we've been working on as we put together this dashboard. And I think even just learning from this has been an important exercise. And last but not least, despite these challenges, I think you'll see when we go through the demonstration that despite these limitations, we can see important patterns and meaningful patterns and patterns that have implications for policies and actions. So I think right now I will turn it over to Usama, who will walk us through some of the features of the dashboard. We will have time for questions at the end, so please save your questions. You can type them into the Q&A, and we'll be responding to any questions that you have as we go through this.
Thank you, Anna, and thank you everyone for being here. And Anna said, my name is Usama Bilal, and I'm one of the co-investigators of this project. So what I want to do today is to show you a little bit of the dashboard, show the kind of things that you can do with the dashboard, and the kind of information you can find there. But first of all, I want to highlight that when you go to COVID-inequities.info, which is the main webpage for the dashboard, the first thing we do is show a little bit of an overview of what the dashboard shows, but we also allow viewers to see our equity framework, which Anna just summarized, with inequities at multiple levels, and also some of the bibliography we're using to draw a lot of the theory behind this dashboard. We also have a specific part where we talk about the inequities that we are using, including individual, neighborhood level indicators, and also city level indicators. And last, we also have a blog section where we summarize issues that we believe are key in the study of inequities in COVID-19. And I want, for example, to highlight this blog post by one of our investigators who has, using data, shown the importance of using age-adjusted rates in COVID-19 disparities. So the dashboard itself, which, as I said before, you can find if you go to COVID-inequities.info and click on Visit Our Dashboard, and that brings you directly to the homepage of the dashboard, in which you find this structure throughout the entire dashboard with a sidebar and a central area where most of the indicators will be shown. These links here just link to the website we just visited now, and can be used in case you have questions about why we are doing things in a certain way, what indicators we are using, and what inequity metrics we are using, along with a list of blog posts and an overview of the sections of the dashboard. So I like separating the dashboard into two parts. One of them is city reports, which is the area where we summarize aspects related to every city. On one side, we have an area where we summarize trends, and an area where we summarize inequities. And then the second section of the dashboard focuses on comparing cities to each other, both in terms of trends and in terms of inequities themselves, with a final section that provides more information about the data and the people that are part of this thing, along with the organizations that are part of it. So without further ado, let's go to the first section of the dashboard, which you can access by either clicking here on City Summaries or going here to the left to City Report Summary. And here we land in this page, where essentially what we can see is a summary of the trends in our cities. Now, not all of the cities are releasing data on the same indicators with the same timeliness, so each of them may look different. But in here, we can see a lot of the cities for which we have data on trends. And for example, here we have Chicago, where we can see a summary of the values up until now, cumulative values, and then how they have evolved over time. We present this in two different ways. The first one is this one, which is the normalized trends, in which what we do is acknowledge that the evolution of the epidemic has been very dynamic by city. There are cities that were more affected in April, March, May, cities that were more affected in the summer, and cities that were more affected in the fall. And in this case, what we show is trends normalized to the peak in each of the cities. So in this case, for example, in Chicago, we show how hospitalizations, cases, and deaths have varied over time with respect to each other. But we can also see them separately. Instead of seeing them as an overlay, you can also click here and see how cases have evolved over time, how deaths have evolved over time, and how hospitalizations have evolved over time. Then we have a second section where we focus on testing, specifically the number of daily total tests, the number of daily positive tests, and the positivity, or the percentage positivity, which is this blue line that you can see here. Now, as I said before, we can select other cities. So for example, instead of Chicago, we can select New York City and see a very similar figure here, where we see that that first wave here in New York City, followed by that second wave that is currently going down in New York City and in a lot of the cities in our sample. Second, we start with the part that we believe is the most interesting part of our dashboard, which is the focus on inequities. So what we see in every, whether we look at New York City or other cities, is that we have separated this into two sections. One of them focusing on inequities by race and ethnicity, where we show different outcomes and how they compare in different race and ethnicities. We had to make a choice into what categories to be able to include here, and we went with these 4 categories because they represented the most commonly available race and ethnicity data across most of our cities. So we separate most indicators into these 4 groups: non-Hispanic Asians or Pacific Islanders, non-Hispanic whites, non-Hispanic blacks, and Hispanics. Now, what we do in this part of the dashboard is allow viewers to check whether inequities vary by type of indicator. So for example, in the case of New York City, what we can see is that the age-adjusted death rate for the Hispanic and for the non-Hispanic Black population of New York City is much higher than for the other groups here. You can actually, if you want a more in-depth interpretation of this, one of the things you can do is highlight one of the bars, and you get a detailed explanation of what these numbers mean. So for example, in this case, a rate ratio of 1.9 means that the mortality rate for Hispanic residents, in this case of New York City, is 90% higher than the rate in white residents. And a rate difference of 148 means that the rate is 148 deaths per 100,000 higher for Hispanic residents than the rate for white residents. We can see the same for all of the other groups. Now, if we are interested in something beyond mortality, we can also look at other outcomes. We see very similar disparities in the case of hospitalizations. We can also look at incidents, where we see that the disparities are a little bit narrower, mostly and most likely due to differences in the access to testing. Now, that's the first aspect of inequities. The second aspect of inequities that we can see within every city are inequities by neighborhood. Now, in order to do this, we proxy neighborhoods by zip codes, which we know are imperfect measures of neighborhoods, but are normally the most readily available type of spatial data in most cities, especially in the middle of a pandemic. Now, what we allow the viewer to do here is to look on the left-hand side at COVID outcomes by type. So we can look at incidence, testing, positivity, or mortality. Let's, for example, click on positivity here. And we can see how New York has areas, obviously areas with lower positivities, for example, here in Manhattan and in Brooklyn, and areas with higher positivity up here in the Bronx, Queens, and Staten Island. Now, on the right-hand side of this figure, what we can see is a number of social environment indicators. If you want more details on that, you can click up here, and that will bring you to the part of the website where we detail all of those. And as an example here, we show the Social Vulnerability Index, which is an index created by the CDC to highlight potential vulnerabilities of a population to pandemics, natural disasters, etc. So it's a good summary of overall conditions in a neighborhood. And as you can see here, the two maps look relatively similar, with darker areas on the right coinciding with darker areas on the left. Now, for those of you that are more data oriented, you may also appreciate that we have included a scatter plot down here, where you can see how the Social Vulnerability Index correlates with positivity. Now, one of the things you can do, and one of the things that I find most interesting about this scatter plot is that you can interact with it. And, if I were to ask someone what will be something that is interesting about this, is that, well, what is happening with those areas up there, right? High positivity, low social vulnerability. So one of the things you can do is click and drag and select those areas. And then try to see here in the map, okay, so these are areas that are maybe different from the other areas. For example, a lot of these zip codes with low social vulnerability by high positivity are down here in Staten Island. So for people that are from the area, this may result a lot more useful than just an overall description, where you can go zip code by zip code to check how they are, how they vary by both an exposure on the right and an outcome on the left. You can choose other indicators here. We have sorted them with how correlated they are with the outcome. So for example, this is the component of the Social Vulnerability Index that deals with household composition. And we can see that it follows a similar trend as the other one, maybe with a bit of a stronger correlation. And then other aspects that may be less correlated with each other, or maybe inversely correlated. So for example, down here, we can find the percentage of the population that has completed college education. And as you can see, now the map looks inverted, where dark areas on the right are light areas on the left. And again, you can do the same thing and look at this scatter plot to look at how this very strong correlation in these cases. Now, this is not the case just for New York, but we can, for example, see the same thing here in Philadelphia, where we can compare incidence, hospitalization, and mortality rates by race and ethnicity. And we can also look at the different neighborhoods. And for example, look at how social vulnerability correlates with hospitalizations, which you can see again, sadly, a very strong correlation. Now, again, you can do the same thing as before, or you can even do it in a different way. You may be interested, for example, in understanding how West Philadelphia is in this plot, and you may be interested in, for example, checking that zip code and saying, okay, that zip code has a social vulnerability that is relatively high, and here on the left we can see its hospitalization rate. Now, what this allows is for you, again, to go through each one of the cities. Now, we believe that one of the most interesting things of this dashboard is our ability to compare different cities. And that's the second section of the dashboard that we can find down here in the Compare Across Cities dashboard. So let's go to the first part there. So here, in this city level and trends aspect, what we do here is try to aggregate data across all of the cities to be able to show them at the same time. Now, in order to have timely data, in this case, we have to rely on what Anna mentioned before, we call county proxies, which are the counties, mostly the counties that are contained in the city. Now, one of the reasons we use this is because county data tends to be more readily available than city data. So where available, we use city data. Where not available, we use the county proxy where the city is located. So here, what we show in this first part is here on the right, we show the overall trends. So we can see very clearly the beginning, March, April, then an increase around the summer, and then the post-Thanksgiving, post-fall, and post December holidays increase with a current strong decline across all of our cities. seeing a very different pattern in the case of deaths. And on the left here, what we can see is each of our cities or their respective county proxies, how they are doing compared to each other. So for example, in terms of new cases per 100,000, we can see that there is a city up here, which is New York, that currently has one of the highest rates, along with Miami down here. Now we can also look at other indicators. For example, here, the percent change in new cases per 100,000, which I have to say, I'm very happy to say that this is the first time I see so many blue in this map, which means that rates are falling in most of the cities, with the exception of New York, where they are roughly stable. Now, if you are interested in a longer time scope, you can do four weeks. And if you are interested in deaths, you can do also deaths, where you can see that the picture is a little bit more heterogeneous because deaths come a little bit delayed with respect to cases. Now, this gives you an overview around the country. This gives you a total overview, summing all of the cities. What if we were to separate them by some characteristics? And that's what we do in this part down here, where essentially what we do is allow you to recategorize cities according to certain characteristics. The first one we show here is a census region, where we use the census regions to categorize cities into Midwest, Northeast, South, and West. And on the right, what we do is show the amount of new cases per 100,000, the total number of new cases, and the proportion of new cases that are in each census region. And as you can see here, we can tell the story that I think most people that have been following the pandemic know, which is a big start in the Northeast, followed in the summer by a stronger increase in the South, followed by an increase in the Midwest, that it then is followed by a super high increase in the case of the West, cities in the West in December and January, along with other increases in other areas. But you can also check other things. And there's one that I especially like, which is the population density one. Some people may remember, especially at the beginning of the pandemic, density was being mentioned as maybe one key indicator that will increase the vulnerability of cities to the pandemic. And what we see here is that indeed, in April, in that first wave, cities with high density were the cities where most of the cases were happening. That was not the case from then on. We actually said that the increase in the summer, which was focused on cities in the South, was more centered around low density cities. And then we see that now, regardless of density, it looks like incidence rates are very similar across cities of different densities. But this is not only something about that built environment things, we can also check other aspects. For example, the proportion of the population that is Hispanic in a city, where we see big increases in the summer in areas with high proportion of Hispanic, most likely due to our Texas and Florida cities. And then in December, most likely due to our Southern California cities. But you can choose another bunch of indicators that you can look at in case you want to see how the epidemic evolves in cities grouped by all of these indicators. Now, one last thing before we go into the inequities part is that you can also check how the pandemic has evolved city by city, but trying to compare them with each other. In this figure, what we allow the viewer is to check, very similar to the trends figure that we saw in the city reports, where we can check how a city has evolved over time with respect to their peak. And we can add more cities here. Right now we have added Charlotte, Miami, New York City, Philadelphia, and San Francisco, but we can even select all of the cities here. And we can get an overview of how the pandemic has evolved. And this may look like something we usually call this an spaghetti plot, because it's kind of a mixture of things, but I like looking at it because it really shows us this trend of an increase in April, May, second increase in some cities in the summer, and then the situation a few months ago where all across the board we were seeing very high incidences. But we can be a lot more detailed and, for example, try to select here, I'm interested in comparing how Baltimore and Washington, D.C. and Philadelphia have changed over time. Cities here up in the mid-Atlantic. And we can see these very similar trends with the exception of Baltimore in the summer and an earlier increase in Baltimore with respect to the other cities. Now, that's if we only are interested in trends overall. But as we said before, one of our biggest interests is comparing cities to each other in terms of inequities. And that's where the comparison of cities by inequities comes in. And in this area, we have three aspects which align with those parts of the equity framework we mentioned before, which are individual level inequities, which we call them individual level inequities so people know what to look for. But in reality, of course, these are socially structured factors such as race and ethnicity, which emerges from systemic racism at the societal level that then ends up generating differential outcomes in different racial ethnic groups. And that's what we are showing here, those differential outcomes by racial ethnic group across all of the cities. So in this first part, what we allow the viewer is to select cities, racial ethnic groups, and compare different outcomes across these cities. So in this case, for example, we are comparing incidence, comparing non-Hispanic whites to non-Hispanic blacks across all of the cities in which we have this kind of data. And as you can see, in general, with a few exceptions, the incidence rates in non-Hispanic blacks are higher than the incidence rate in non-Hispanic whites. Now, these disparities are even more marked if we look at things such as mortality or hospitalizations, where fewer cities are reporting this, but differences are even more striking. Now we can add more racial ethnic groups here. We can remove racial ethnic groups and be left with whatever comparisons we are interested in. Also, we can look at filter by cities that have age-adjusted data. In this case, if I click here, we'll only show New York City, which is the only one that is showing this in a really available way. But you can also do that in case you are interested in seeing the rates in that sense. The other thing we are doing in this is allowing you to see how cities, how the gaps are in each city. So for example, let's look at differences in positivity between whites and Hispanics. And what we can see here, first of all, is that there are only 4 cities that are reporting this type of data that are in our dashboard. In this case, San Diego, Portland, Los Angeles, and Chicago. And what we see here is huge disparities. So for example, if we are to look at Chicago down here, and we highlight the tooltip, we can see that the positivity is 37% in the case of Hispanics and 17% cumulatively through now in the case of non-Hispanic whites. We see that there is a rate difference of 20 and a rate ratio of 1.18. Now, we also provide an interpretation of this. For example, this rate ratio means that the positivity for Hispanics is 118% higher than it is for whites. We can do this for other outcomes and for other racial ethnic groups, and we can sort it in many different ways. So for example, if we are to look at mortality, and we want to compare the mortality in non-Hispanic blacks to the mortality in whites, we can even sort it by the difference here. So for example, let's sort it by the rate ratio. And what we can see here is that, for example, a city such as Chicago has the widest gap between non-Hispanic blacks and non-Hispanic whites, followed by Portland, Boston, and New York City, while Columbus, Cleveland tend to have the lowest disparities in this case. Last, and this is a comment that we have gotten consistently because people working with the data have seen this, is, okay, you may be seeing these disparities, but how complete is this data? How complete is the racial ethnic data that is being reported by different outcomes in each city? So one of the things we have done as we compile this data is also compile the data of the percent of the cases, percent of the hospitalization, percent of the test, and percent of deaths that have racial ethnic data by city. And we allow a comparison between them because we believe that this is very, very important in the context of interpreting these differences in rate between racial ethnic groups, because the differences may even be wider if we were to have complete data. In this case, what we allow people to see is select an outcome, for example, testing, incidence, hospitalization, or mortality. Here we see that in San Jose, there is around 10% of cases with missing race and ethnicity, and this number is around 22% in the case of Chicago. Also, if we look at mortality, we see, first of all, good news, it's that the numbers tend to be lower. If we look at testing, there are far fewer cities that report this, and those that report it acknowledge that there is a high level of missing data in the case of tests. For example, varies between 26 and 50%, which is pretty high. Now, Again, in the case of hospitalizations and mortality, these numbers are much, much lower, less than 12% in all cases. Now, that's the case for outcomes by race and ethnicity. We can also compare outcomes by neighborhood level variables. What we do in this part is, you may remember, let me go back for a second. You may remember that we were able to see how well certain indicators correlated with certain outcomes. In the case, we see that in Philadelphia, the social vulnerability index is highly correlated with the rate of hospitalizations in a given zip code, right? You can see that very well here, quite straight line here. So how do we summarize this? Well, we decided that in order to summarize this, what we will do is categorize all of the neighborhoods in each city by whether they are at the top levels of a given variable or at the bottom levels of a given variable. So in the case of a social vulnerability index, we group neighborhoods in those that are at the top versus the bottom quartile in terms of social vulnerability. And then we compute all of these COVID-19 indicators in those neighborhoods and show them here. So in this case, what we are showing is incidence in neighborhoods that are at the top versus bottom social vulnerability. In orange, we see the top social vulnerability, so neighborhoods with more social vulnerability according to CDC. And at the bottom, in purple, we see neighborhoods that are in the area of least social vulnerability according to CDC. Now, one clear pattern we can see in this figure is that with very few exceptions, neighborhoods at the top social vulnerability, so neighborhoods that are more socially vulnerable, according to CDC, have way higher incidence rates. And you can see an extreme example here in San Jose, where neighborhoods at the top of neighborhoods that have the highest levels of social vulnerability have an incidence of 8,700 per 100,000, while neighborhoods in the least social vulnerable areas have an incidence of 3,200 cases per 100,000 with a rate ratio of 2.71. So very, very wide differences in the case of San Jose, but this applies to most of the cities too. Now, imagine you are interested not in social vulnerability, but something more concrete. Let's look, for example, at overcrowding. So in the case of overcrowding, which in the case you are interested, is defined as the percent of people living in a housing unit with greater than one occupant per room. And in any indicator, you can just overlay this I information button if you are interested in the indicator. And we see a very similar picture. Areas, zip codes with the highest overcrowding have a much higher incidence rate in almost all of the cities, with a couple exceptions, than neighborhoods at the lowest levels of overcrowding. And again, you can hover over and check the specific numbers for every city, and even the specific numbers for each variable. Like in this case, we define highest overcrowding as neighborhoods with more than 9% overcrowding, and lowest overcrowding in neighborhoods with less than 2% overcrowding. And if you are interested in the precise interpretation, you can actually find it here in the tooltip. Now, we not only look at incidence, but also at other factors, such as testing, positivity, hospitalization, and mortality. Now, depending on which city you are looking at, you will find more or less of those. So, for example, positivity tends to be less available. There are far fewer cities that report that at the neighborhood level. But as you can see, consistently in all of these cities, neighborhoods with highest social vulnerability have way higher positivity than neighborhoods at the lower social vulnerability. And again, if you are interested, you can see all sorts of other indicators here, such as, for example, the proportion of people with completed college, in which case we find the lowest, an inverted relationship. So the neighborhoods at the lowest levels of college education tend to have higher positivity than neighborhoods at the highest levels. And you can resort this by any aspect that you see on the figure. Now that's for neighborhoods, but as we said before, we are also interested in comparing cities to each other in the case of city level indicators. So that's the case of city level inequities. Now in this case, we show a relatively similar figure with a few exceptions. In this case, what we do is we group cities by certain variables. In this case, we show a few of them: racial ethnic composition, poverty, income inequality and a few segregation variables. And what we do is we group all of our cities based on whether they are at the top or bottom quartile of these variables. So for example, in orange here, we see cities that are at the highest quartile of percent Hispanic. And if we hover over here, we see that that means that these cities have more than 35% population is Hispanic. While in purple here, we see the cities that are at the lowest percentage of proportion Hispanic, in this case, less than 10%. And what we see here is that consistently, cities that have a higher proportion of Hispanics or a higher proportion of non-Hispanic Blacks, or that have higher segregation as measured by the dissimilarity and the isolation indices, tend to have higher incidence. Again, same thing with cities with higher poverty. Now we can do this by several other indicators. All of the indicators that we showed before, you can actually select them here and add them to this figure. So for example, we can see whether cities with more or less overcrowding have higher or lower incidence, cities with higher or lower population density have higher or lower incidence, but we can also do this for other indicators, such as testing, positivity, and mortality. Now, if you are interested in knowing which cities in each one of them, you can actually see that in the tooltip. So for example, here, cities in the top quartile of density versus cities in the bottom quartile of density. You can see that at the bottom of the tooltip. You can see that at the lowest end of density, we have cities in Austin, Charlotte, Fort Worth, Houston, Indianapolis, Kansas City, and Phoenix, and San Antonio, while cities at the top quartile include cities in the Northeast and Midwest. Okay. You can also, as before, you can sort this by other aspects, such as, for example, which are the indicators that have the widest differences or disparities, and which are the indicators that have them on the other direction. So these are indicators where the bottom quartile has higher incidence. These are indicators where the bottom quartile has the highest, lowest incidence, sorry. And again, as with all of the other pages, any details on the indicator, you can find them on the page itself by hover over in the tooltips, or you can also click here to go to the part of the website where you can see all of the indicators with a description of all of them, how they are calculated, where they are obtained, etc., for all of them. In the case people are interested in, of course, replicating this. Then last, I want to highlight that if you're interested in knowing exactly where the data is coming from each of the cities, we have the data tab, where we indicate for every city where the city trends data comes from, where the neighborhood data comes from if it's available, and where the inequities data comes from if it's available. So in this case, for example, I'm going to show the top 5, where we can see that Austin, Baltimore, and Charlotte, and Chicago all have city trends data coming, in some cases, from the city itself, at the city level. In the case of Charlotte, coming from the county, from Mecklenburg. In the case of Chicago, coming from the city itself. In the case of neighborhood level data, we see that Baltimore, Charlotte, and Chicago have it available, all of them at the city level. In the case of inequity data, we have data for Boston, Charlotte, and Chicago. In some cases, the data is updated to almost yesterday or a couple of weeks ago. In some cases, as Anna said before, there are challenges in accessing some of this data, so a little bit of it is less updated, but you may have noticed how in each figure, you can actually click here in case you only want to see rates in cities that have been updated in the last 30 days. Last here, in the case of data, down at the bottom, we also see in the cases where we use county proxies, we show which county is the proxy and what is the FIPS code in case people are interested in also using that. And down here, we provide details on the data sources for some of the other things, such as the American Community Survey, the Social Vulnerability Index, or how we calculated the index of the concentration at the extremes. And last, but definitely not least, I want to thank the Big Cities Health Coalition for really engaging us with this work and providing us with the platform to discuss this thing with the cities. Also the Deb Beaumont Foundation and the Robert Wood Johnson Foundation for the generous funding of this dashboard. And last, and definitely not least in this case, the contributors for the dashboard, the team here, which includes a huge multidisciplinary team, including students, co-investigators, postdoctoral fellows, and a wonderful set of staff people that have been managing the data, the dashboard, contact with the cities, etc. This is truly a team effort. Thank you, and now we'll open it up for questions.
Thank you, Sama. You can go ahead and type any questions that you have into the Q&A or the chat, and I will read them out. We already have a couple, Usama. There's a couple of questions on the race ethnicity categorization. One says, how do you categorize biracial? And for those cities that report a lower percentage of race ethnicity, I assume this means less complete race, less available race ethnic information. Do you artificially assume that the non-reports would follow the reports and that the total percentage is the same as what has been reported?
Great question. And this is something we have definitely struggled with, especially in our contact with the cities. Right now, we are reporting these 4 categories because we found them to be the most consistent across cities. Now, we acknowledge that we are missing very important categories. I want to highlight that we are missing here Native Americans, which have some of the highest incidences and highest mortality rates. Now, the number of cities that report rates for Native Americans is sadly very small. So we've tried to come up with something that was most comparable across cities. And actually, we learned a lot from talking to the cities about this. On the second question, on that part of the question, most of the cities are reporting based on X category alone. And they tend to lump all of the other categories that are biracial, multiracial, etc., into an other category, which we also believe is extremely problematic. And as you can see, we never list an other category here because it tends to be quite a heterogeneous group that doesn't really provide much information. Unfortunately, considering the data we have, this is the best we could come up with. Second is very important, what happens with missing data. What we believed in doing here was in showing all of the potentially available data. That is, we are showing this, but also in the same page, we are showing what is the percent missing there. So that if someone is interested in understanding whether the data for San Jose and Fort Worth is comparable, well, you can come here and then decide based on that. We cannot assume that this up here represents the full scope of racial inequities because of this down here. Now, I wish we had better quality of this, but we believe that one of the interesting products of this dashboard is actually showing this figure here, where we show the percent completeness. Trying to hide it, we believe, is not the right approach, and that's why we are showing it.
Thank you. So we are just showing what is reported. We are not making any assumptions about what's not reported. If it's not reported, it's not shown. That's basically, and I think one of the things that has emerged in this project, as in many other projects, is, some of the challenges in standardization of data across not just cities, but, the whole country. So another question is about the measure of overcrowding. If you could say something about the measure of overcrowding, who determines that, where it comes from?
Sorry, our measure of overcrowding comes from the American Community Survey. And actually, if people are interested in the specifics in the website, in the indicators part, we have the detail of each one of them. In this case, we use, there are 3 commonly used, to our knowledge, there are 3 commonly used overcrowding indicators, but all of them are based on the same data. And they tend to be the percentage of people living in housing units that have more than X% of people per room on average. X here is the thing that varies. It varies normally from 1, 1.5, or 2. And those 3 types of indicators are the ones that the census and the HUD most commonly report for overcrowding. We decided to go for 1 instead of 1.5 or 2 because a number of our cities have had actually very few zip codes with extreme overcrowding. So we believe that a limit of 1 had a better representation of the situation in these zip codes.
There's another question about, can you explain what is being done with this data and who is using it? Are cities using this to create different policy and programs for right now, or is it to understand trends going forward? I'll take a quick stab at that, and someone might have something to add, I'm sure. So, or Jen Coker, who's also part of the project. Right now, so this began as a collaboration with the Big Cities Health Coalition, and so in the hopes that these comparative city data might be useful to the cities themselves as they think about their strategies going forward. But we think it may have broader utility to other stakeholders and audiences who are interested in visualizing these inequities and thinking about what are the best strategies going forward. And we've just launched this a few weeks ago, really. So we hope to learn more from the users about what we can do to make it more useful. I don't know, Jen, if you have any comments you want to.
I would just add, and it was an answer to another question someone asked about vaccine. We also have a project that we're starting to look at testing, and hopefully we'll start to look at vaccine also and kind of incorporate other data elements as we move forward.
I want to add there that one of the things we are doing with the blog here is to showcase uses of the dashboard. Right now we have just a few things, but one of the things we have done is just check how the incidence rates in each of the cities have changed after the reopening of indoor dining. Like that could be an example of that.
There's another question about whether we'll make available a copy of the presentation. So the demonstration that Usama did is live. There's no slot, it's live demonstration. So, but we have taped this. So the recording, I believe, will be made available. I don't recall where, maybe someone can chime in or type in the chat where and when it will become available.
All of the registered people will get an email in about 7 weeks with the recording.
Okay. A few other questions. Vaishnavi, I think the question about the presentation was, did you want to jump in there? I see a note from you, or was it answered?
Nope, just saying that it was answered.
Okay. Another question is, for the comparison of different indicators, incidence, death, hospitalization rates, etc., in high versus low quartiles for social indicators for different cities, I presume that the differences in rates among cities reflect differences in the high, in how the high is defined in one city versus the high or low in another city. Is that correct?
Yes. So I think the question is about this one, where we are looking at, for example, what's the positivity in areas with the highest college education versus lowest college education. Philadelphia, for example, the percent with the highest college education is 48%, that top category, while in Chicago, that's 71%. So yes, this is city specific. The top and bottom are city specific.
There's another question. There was a question about something you just said, Usama, about the correlation between mitigation strategies and changes in rates. I think that was the comment you made about the indoor dining. Yep. There was, I guess, a question about, can you restate that, perhaps, the comment that you made about that?
So one of the things we have done as a very exploratory thing as part of the blog post that people can go and read that is that we have taken this data and tried to see what happens, for example, after a city opens indoor dining. So that's one of the blog posts that people can take a look here. So our intention with this part of the dashboard or the website is that we can showcase uses of it. For example, we have a blog post incoming where we show, kind of this idea of demystifying big cities as the hotspots of COVID-19 and how there are way more factors than size that influence this incident. So.
Okay, I don't see any more questions at this point. There's one additional question about access, whether the Big Cities Health Coalition members have access to what's reported, if I understand the question correctly. And yes, of course. I mean, the idea is for these data and these visualizations to be useful to the cities themselves.
She's asking actually Anna, about funding streams. I'm not sure what funding streams we're talking about. We're not currently collecting data on individual funding streams to individual cities. We're really just looking at the data that's coming out. I know, as an aside, one of the things the Big Cities Health Coalition looks at for their member cities is overall how we fund public health infrastructure funding, and resources that we invest in overall public health, but especially when something like a crisis like this comes up. So I think there probably will be more coming out of BCHC and potentially also in the future.
Any more questions? Well,
I saw something popping on vaccine data, and just want to highlight one thing that is very, very important for everyone in general, which is that we would love if this wasn't, like, if this picture of high missing data won't happen with vaccines. And that's really something that we are very, very hopeful that vaccine, race, ethnicity data, zip code data, etc., is collected timely and completely, because the only way to monitor these trends and the only way to decrease these inequities, all of that goes through understanding that they are happening and where they are happening. And without data, with 50% missing data, it's very hard to assess that, because we know, as someone asked before, that the people with complete data may not be representative of the entire set of cases, vaccines, etc., etc. So I want to reinforce the importance of having good data, and we know that that's challenging in the middle of a public health emergency, but that's definitely something that we want to emphasize here, the importance of good data.
There's another question about the potential to link some of this data to the NACCHO survey of health departments. I think, yes, I think one of the things that is very interesting about this data is the potential to link it to other data sources to better understand the differences that we see, the factors that might be driving them. So we hope as people use the dashboard, they'll get ideas about additional things that could be done.
And if people have more of those ideas or things they would like to see incorporated here, like we know this data source that had this very interesting thing at the city level that we think would be great to incorporate here, please do not hesitate contacting us. You will get, when you get the 7-day follow-up email, you will get Edwin's email, Edwin Macaulay, which is the research coordinator that is coordinating a lot of these things. And please email him with any ideas that you have, because we are really open to linking this to more data, the zip code level, census tract level, city level, county level, etc.
Okay, I don't see any more questions. So we will be sending out details on the recording in 7 days. Is that correct? And you'll have information on how to contact us. And in the meantime, we hope that you will look at the dashboard, explore it, play around with it, and send us any input that you have about how we can make it more useful and better. So thank you all for joining, and thank you to the whole team for the presentation, and we will be back in touch. Thank you very much.
Thank you, everyone.